garner your interest as well. That's why you'll feel sleepy. So as far as possible, try to answer the questions yourself as well. I've arranged it in such a way that I'll give a picture and give a brief history, and then you can go back to the picture and decide what it is. So I think that will help you to improve your knowledge as well. And you can ask me questions if you want to, no problem. Since we are short of time, I think without much further ado, we'll move on. Right. So let me share the screen. So this is the first patient. I hope you can see two, the lower limbs, the soles, and this is a 3-year-old male with low-grade fever for 2 days, reduced oral intake and irritability, right? So he presents with this rash. Any ideas, anyone? What do you think? And what do you see?
Hand foot mouth.
I'm sorry?
Hand foot mouth
Yes, you're
disease.
right. That's correct. This is hand, foot, mouth, right? So, although we typically talk about the feet, hands, and the mouth, you can have other areas of involvement as well, like the buttock, elbow, knee as well, the knee, elbow, buttock area. Sometimes it can be very profuse all over the body, almost like chicken pox, especially in children who are obese, who don't wash their hands frequently, and also who have not been breastfed. They can have more severe infections. Sometimes it can even mimic vasculitis, especially the lesions on the sole. So this is hand, foot, and mouth disease. You can have oral lesions like this. Sometimes it can be quite subtle as well. You can hardly see the skin lesions. So usually it's caused either by Coxsackie virus A16 or enterovirus 71. In adults, Coxsackie A6 might be the cause. You can't clinically distinguish very easily, but generally enterovirus 71 infections are more severe. In most cases, it's a very mild condition. You get a low-grade fever associated with lymphadenopathy, after-like erosions, small macules, which evolve into small blisters. And usually there are no complications, but very rarely, especially with the enterovirus 71 group, those infections, you can have CNS manifestations such as acute flaccid paralysis, encephalitis, meningitis, seizures, and very rarely you can have even cardiorespiratory failure leading to death. But that's extremely rare. And Bose lines are a common complication, especially the child is brought by the parent several weeks later and with concern about the nails, right? So in fact, this happened to me yesterday. This patient came yesterday. When you go back in the history, the mother said that the child had hand, foot, and mouth disease 5 weeks ago. So you can see you get a transverse groove or a split, and the superficial part of the nail comes out, and they are quite concerned about it. But usually the nail grows back. So this condition was actually described by a French physician called Joseph Beau, and it's thought to be a transient arrest in the nail growth due to a metabolic or infective insult, normally due to hand, foot, and mouth, dengue, COVID, uh, any strong viral fever. You can have this, and it's usually self-resolving. So, any questions on that first patient? So, I presume there aren't because I can't see any questions. So, let's move on to the second question then. Okay. So, this is a second patient. So, you can see this little boy with this rash. Let's see what the history is. So, it's a 1 year, 10-month-old boy with a
Sir,
rash
we
on the
can't see
face
the
since
slide,
six
sir.
months. I spoke about the hand, foot, and mouth disease. I think you all saw this, right? So, basically, uh, these were the nails I was talking about. You can see the horizontal grooves, and this area where the nail separates, but it's only a transient phenomenon, which is due to the transient arrest in nail growth, right? So this is patient number two. So patient number two is this boy who presents with this itchy rash on the face since 6 months of age. Development is not very significant, the antenatal and postnatal history. He's 1 year, 10 months old. His mother has a dry, scaly skin rash involving her shins. So have another look. So what do you see? You see the skin is dry, ill-defined, scaly, slightly erythematous. What do you think about this rash? If you look carefully, you will notice that he's having a runny nose as well.
Atopic dermatitis.
Atopic dermatitis. Is that clear? Right. So, what is atopic dermatitis? I'm sure you all know this very well. So, it's a chronic pruritic inflammatory skin condition. Now, generally, it doesn't come at birth. It usually starts after about 4 months of age, 4 to 6 months. So, if you get a child with an eczematous rash at birth, you have to be a little bit more careful whether it could be a part of an association of a syndrome or whether the child is having an immunodeficiency. So, those should run in your mind. Now, atopics are people whose immune system access like the immune system works a little bit differently. So, atopics, wherever their body comes into contact with the external environment, you get an altered immune response. For example, if you inhale antigens into your lung, you get asthma. Contact of exogenous antigens into the nasal passage, you might get allergic rhinitis. In the skin, you get atopic dermatitis. Any ingested antigens might lead to a dermatogenic enteropathy. So in these people, they may have elevated IgE levels, and usually the disease progresses sequentially. You start with atopic dermatitis, move on to food allergies, asthma, and allergic rhinitis in what we call an atopic march. So usually they have dry skin, which is called cirrhosis. It can be thickened with prominent skin grooves and marks, which you call lichenification, and eczematous lesions like we discussed. And eczematous skin is more prone for infection, bacterial infections like staphylococcus, streptococcus, MRSA, viral infections like herpes, you get eczema herpeticum, and other viruses like eczema molluscatum due to molluscum. And the site of skin involvement varies with the age. So in the youngest child, infant, up to 2 years, you can see prominent flexural involvement of the face, convexities of the face, like in our child. You can have extensive involvement of the limbs, neck, flexures, and the groin. In older children, it moves on to involve the flexures of the knee and the elbows, and gradually the face clears up. Especially in teenagers, due to most oily sebum production, face is comparatively spare. So here are some more pictures. It's an ill-defined erythematous scaly rash. Here you can see some degree of lichenification on the extensor aspect of the ankle and flexural aspect of the knees. You can have perioral or periorbital involvement like in this patient. You can have in a photosensitive distribution and so many different morphologies. So idiopathogenesis is very complex and multifactorial. So multiple factors are at play. You can have a genetic predisposition. People in the family, mother, father might have eczema, allergic rhinitis, asthma, drug allergies, or just dry skin, what we call ichthyosis. Right? So then you can have environmental and lifestyle factors, for example, using harsh soaps, pH unbalanced soaps, then living in a dry, cold environment, or infections like viral after cold or sore throat, eczemas can flare up, stress. Then also with the dry skin, you can get itching. So with the itching sensation, you scratch. When you scratch, you damage the skin. So the skin barrier doesn't work well. Then you have ingress of exogenous antigens due to the dysfunctioning barrier, ingress of organisms, antigens. So this leads to an inflammatory response. Inflammation and the altered immune response leads to further itching and scratching. So we talk about a vicious cycle, the itch scratch cycle in eczema. I hope that's clear. So just roughly touching on treatment because there is no time to talk about everything. It's like a stepwise pattern. The very basic eczemas, we use just moisturizers and education. Then moving on, we move to topical steroids, topical calcineurin inhibitors like tacrolimus and pimecrolimus. Then we add on antihistamines, and then sometimes when it's more severe, systemic immunosuppressive drugs, phototherapy, and so on. So I'll move on to the next patient because we are running short of time. So you see this child with a focal patch of hair loss, and there seems to be some white hairs or leukotrichia growing in it. So it's a 5-year-old male with a focal alopecia of the scalp for 3 months duration with white hairs. The hair margins are involved. Scalp actually looks normal, the involved scalp, and the other areas are normal. Does anyone know what this condition is? Any guesses? So it's a non-scarring focal alopecia. So this is actually alopecia areata, right? So it's a non-scarring alopecia that can occur at any age. Usually it's very focal, but rarely it can involve the whole body and the scalp. It's autoimmune in origin and can be associated with other autoimmune conditions such as thyroid, diabetes, lupus, and vitiligo. Now, speaking of vitiligo, it's quite important really because we spoke about leukotrichia or the white hairs. Now, the reason is vitiligo is due to the autoimmune destruction of the melanocytes of the skin. In alopecia areata, the hair damage is again autoimmune, and at least part of the autoimmune response is directed against the melanocytes of the hair. So, as a result, the hairs that grow may be lacking in melanin, so it appears white. And also in older people, white hairs are spared of the immune response, so they may have white hairs remaining even after the other hairs fall off. So that's why you see uh, leukotrichia in alopecia areata in some patients. Sometimes it can take bizarre shapes like linear patterns or serpiginous patterns like this, odd shapes like this. So we must not mistake it for trichotillomania. In trichotillomania, you will have remaining damaged hairs of varying lengths, and the surrounding skin won't look normal. There will be epidermal changes due to the picking of the skin. Sometimes you can have, as we discussed before, alopecia totalis where the entire scalp is involved, or alopecia universalis where all the body hair bearing sites are involved. So we'll move on to the next patient. This is actually an easy one. So I'm rushing a little bit since we are short of time. So this is a patient from the estate sector with a generalized itchy rash. Itching is worse at night. So what is the diagnosis? I think this is fairly straightforward, isn't it? So you can
Scabies.
see scabies, exactly. So it's a flexural involvement, finger webs are involved, there are itchy papules, and it's worse at night, living in old overcrowded setting like the estate sector. So all those are features for scabies. So it's highly contagious disease caused by a mite called Sarcoptes scabiei with the human variant, Vahominis. It's common in overcrowded settings, and the mites lay eggs which hatch, and the mite burrows in the stratum corneum, which is the most superficial area of the skin. Now, it's not the mite burrowing that leads to the itch, but rather their feces, which has an inflammatory response, what we call skybala. It's their feces that leads to the itch. So these are the typical features we see in scabies. The top left, you can see this linear tract, which is what called a scabitic burrow, which is pathognomic of scabies. So if you see this, you're certain that this rash is scabies. In actually smaller children, because the palms and soles are not very thickly keratinized, you can have scabies involved in the palms and soles quite a lot as well. And you can have tiny blisters coming as well. And you can get scabitic nodules on the scrotum, which are intensely itchy, which is a hypersensitive response to the scabitic antigen. And of course, scabies can be complicated with post-streptococcal glomerulonephritis in children. So it's very important to treat it and eradicate it properly. Now, 5% permethrin is the preferred drug of choice. So generally, we have to treat the patient as well as issue epi treatment to all household contacts, regardless of regardless whether they have the symptoms or not. And usually we have to treat the whole body below the chin, leave it on for 24 hours, and advise them to wash their hand. If they wash their hands, to reapply it. If they go to the toilet, to reapply it. It has to be there for 24 hours, and everyone should be treated on the same day. So after 24 hours, you have to repeat the treatment again, roughly 7 to 10 days. Another alternative in the absence of permethrin is sulfur, 10% sulfur, but that has to be used for 3 consecutive days and repeated after 7 days. So it's very important in addition to this to sanitize the bed linen, clothes, and in resistant patients, especially in crusted scabies, you might have to go for oral ivermectin. So these are all relatively simple patients and cases I'm treating actually, showing you all actually. So this is a hypopigmented rash involving the limbs of a 13-year-old boy. Not only the limbs, the front and back of the upper trunk and the lower face are involved, and it's mildly itchy after sweating. So what is the possible diagnosis? Any guesses?
Pityriasis versicolor.
That is pityriasis versicolor. So now it may look at something simple, but actually sometimes it can be quite tricky to distinguish. Now generally this can be now this is due to a yeast called Malassezia furfur. It can be hypo or hyperpigmented, and especially it can occur in peripubertal age due to the sebum. You can have it involving the eyebrows and the nasolabial folds as well as the cheeks. So here on the left you get the hypopigmented, and on the right the hyperpigmented variant. This is the involvement of the eyebrows and the interbrow area and the lower face. Now usually it's only hypopigmented, but sometimes it can be more almost depigmented rarely, and it can cause problems in diagnosis because we can mistake this with vitiligo. Now you have to bear in mind if you can easily work it out now. Malassezia furfur produces a chemical called azelaic acid, which is a bleaching agent. It's even used in cosmetic creams to produce whitening of the skin. So it's basically azelaic acid is the essence of aluhang, which is used in these creams. So now this, since the Malassezia predominantly lives in the sebum, which is found in the orifices of the hair follicles, because that's where the sebaceous glands empty, the hypopigmentation is primarily perifollicular. But in vitiligo, which is often, it can be mixed up with, the melanin is produced by melanocytes, and even after the melanocytes are destroyed, the stem cells in the hair follicles convert to melanocytes, and they produce melanin around the hair follicle. So here the pigmentation is perifollicular. Here the hypopigmentation is perifollicular. So it's like a mirror image. So it's easy to distinguish the two conditions. I hope I'm being clear. If you don't understand, you can ask me. Right? So treatment, it's important to trace any family, whether any family members also have it. Often they do. So it's important to treat the family members as well. Otherwise, it will recur. So drugs, topical treatment like ketoconazole work very well, especially with pityriasis versicolor. If it's extensive, and in older children, we may consider an oral azole like ketoconazole or fluconazole. But oral fluconazole should be used with caution. I personally prefer to not use it because it can be hepatotoxic. Now, griseofulvin doesn't work against yeast, although it works against tinea. So you can't give griseofulvin to treat pityriasis. So this is also a very simple and common condition. I'm sure this is straightforward. It's a 9-year-old male with asymptomatic lesions for 3 months. So you can see these fleshy papules with a central umbilication or a central day. So these are feature of pox viral infection. So this is actually molluscum contagiosum. It's caused by pox virus, common in preschoolers and school-going children. Usually it spares the palms and the soles, spreads via autoinoculation, stretching, touching, or by fomites. What are fomites? Fomites are inanimate objects which can spread the infection. For example, furniture, doorknobs, etc. Now, usually if you get giant forms or atypical forms, especially in the face or genital area, you have to suspect whether the child could be having STDs or immunosuppression like HIV. So you have to think of that as well, especially in the buttocks or groin, get large giant lesions. Just have that at the back of your mind as well. So sometimes it can be quite tricky to diagnose, but most of the time, if you can find the umbilication, it's easy. So usually we treat it with either KOH or trichloroacetic acid. But even without treatment, most immunocompetent children eradicate the infection after, within a couple of years. So this is the next patient. You might notice it's a unilateral pigmentary problem, right? Which appeared in infancy, and it's associated with leukotrichia. Now you can get depigmentation due to a number of causes, but if it was not present at birth and appearing later on in life, you have to think of segmental vitiligo. There are other causes, obviously, you might be knowing of. Scoliosis, things like Waardenburg syndrome, Peabodism, and so many things can lead to this. So this is actually a segmental vitiligo with leukotrichia. Now, vitiligo is a acquired chronic depigmenting disorder. It's thought to be due to genetic and environmental factors, genetics playing a bigger role, leading to autoimmune destruction of melanocytes. Especially in our type of skin, it causes a lot of cosmetic concern. And it's common among South Asians, including ourselves. And there can be involved first or second degree relatives. And as we mentioned, it can be associated with alopecia areata and other autoimmune disorders. Now, treatment has to be customized according to the patient. Topical steroids, calcineurin inhibitors, calcipotriol, phototherapy can be used. We try our best to avoid oral steroids in children because it can affect the growth. Now, especially vitiligo occurring, especially segmental vitiligo occurring in a prepubertal child, especially when it's associated with leukotrichia, has a poor prognosis. Because leukotrichia means the stem cells have been uh, depleted. So you can't expect new stem cells to form new melanocytes. So like in this patient, if the lesions are stable for more than a year, we would consider surgical approach. So we did a test of punch grafting to see whether it will be taken in where. And you can see after 3 months, the area that was grafted has been taken in well. So he's awaiting further grafting. So we do a test graft first to see whether that gets depigmented. But if it's taken in well, that means the vitiligo is stable and we can go on. So next patient, right? You can see a child with a large boggy mass on the scalp, fluctuates swelling on the head for 2 weeks, but the child is afebrile. He has cervical lymphadenopathy. So I think this is again a straightforward thing. What is this? Anyone knows? Anyone knows what this condition is? So you can see a bit of hair fall, fluctuant swelling. Anyone? No one knows this. It's fairly, I'm sure you'll see it at some point in your career. This is a chirion. What is a chirion? It's due to an animal fungus infecting the scalp and the hairs. Unlike anthropophilic fungi, which are fungus growing in among humans, the animal fungus doesn't know how to evade our immune response. So as a result, it's very inflammatory. So inflammation produces this cold abscesses like, and it forms a lot of pus. You lose the hair, you get lymphadenopathy. So often these patients might be mistaken for having a scalp abscess, and they can be referred to the surgeons. But surgical incision and drainage is not indicated and can lead to disastrous complication. So usually, it's very important to distinguish a chirion from a scalp abscess. How do you do that? How can you distinguish? Both have pus, both are boggy swellings. First of all, a child with a scalp abscess of this degree will be very ill. Will be febrile, malaise, he'll be quite ill. Secondly, since a chirion is a fungal infection on the hair, if you pull these hairs gently, they will easily come off. And at the follicular orifices, the punctum of the hair follicle, if you squeeze it, you will see pinpoints of pus coming out, which you will not see with the scalp abscess. Right? Lymphadenopathy can be even due to a secondary bacterial infection, but even otherwise you can have lymphadenopathy. Now this has to be treated urgently because the severe inflammatory response will damage the hair follicles, leading to a permanent scarring alopecia. So it's very important that in addition to a systemic antifungal such as glycofulvin, we also often add prednisolone to prevent further damage to the hair. And if you are suspecting a secondary infection, we would also add an oral antibiotic. This is also, I mean, a reasonably common condition. You can see very superficial fluctuant bullae with golden honey colored crusting. So this is a 6-year-old child with vesicular pustule eruption around the mouth for 3 days with fever. So I think you all probably can diagnose this. This is bullous impetigo. Is that clear? Can you all hear me?
Yes, sir.
Hello.
Yes.
Yes.
Yes, sir.
If there's any questions, you can ask me. Yeah? So bullous impetigo also can have many forms. Impetigo can have many forms. You can get the bullous variant, pustule variant. And especially if you get impetigo around the nose, you have to be concerned whether there can be nasal carriage, because impetigo, which is often due to staph, can colonize the anterior nares and cause recurrent impetigo. And especially children with eczema are more prone for impetigo. And impetigo involving the face, especially the dangerous area of the face, you have to be careful because infection can spread to the central nervous system by the veins which lack valves in this area. So it can be more diffuse, leading to more flaccid blisters. These black blisters can erode easily because they are very flaccid and have a thin wall, leading to eroded areas, sometimes even circular eroded areas. Now, if the antigenic load is high, the staph antigen load is high, the erosions will be very diffuse and generalized, leading to Staphylococcus scalded skin syndrome. When it's more localized response, only we get this bullous impetigo. So Staphylococcus scalded syndrome is due to the exfoliative toxin, just like bullous impetigo. So commonly due to staph, but rarely streptococci also can cause. So it's very important to treat this early, and of course, especially in atopics, because secondary infections can aggravate the eczema as well. So topical mupirocin, and if it's more severe, oral antibiotics, and decolonization of the nostrils is important, especially in recurrent impetigo. So next patient, I don't think this is a child, but even in children, the presentation is very similar. So it's a painful rash on the upper back for 3 days duration. If you look carefully, it's more or less restricted to one side. It's unilateral rash, isn't it? And you can see clustered blisters, clustered, or as we call it in dermatology, zosteriform or agminate, where you get grouped or clustered blisters. So this is a typical feature of the herpes virus group, including varicella and herpes virus, right? So this is herpes zoster involving the C7 dermatome. Now, herpes zoster, as you all are probably aware, is due to reactivation of the varicella zoster virus or the chickenpox virus. It's not due to herpes, it's due to the varicella zoster. Now, this herpes group and the varicella are notorious to lay dormant after primary infection in the nerve root ganglia and cause reactivation at times when our immunity goes down. Spreads along the nerve root, leads to this segmental zoster, right? So if an immunocompromised person touches this, they won't get herpes, they will get varicella zoster. So often pain precedes the eruption, skin eruption by a day or two. So sometimes they can come with severe abdominal pain, chest pain, acute abdomen. They can be mistaken for acute abdomen. And if they are treated late, post-herpetic neuralgia can be a problem. But usually, fortunately, in children, post-septic neuralgia is rare. Next patient, this is again fairly straightforward. Painless nodules on fingers for 6 months duration. So what is this? I'm sure you all know what this is at least. Do you all know what this is? Can you all make a guess? Painless asymptomatic nodules on the fingers. Anyone?
Viral boats.
Yeah, these are viral ones. So it's the commonest viral infection among dermatology clinic attendees in children. Common in children and young adults, again in the school going age, transmitted by touch, and it can spread to sites of trauma, resulting in linear lesions sometimes. Usually, our immune system can get rid of it within a couple of years, although some can persist for a longer time. So there are different morphologies. You can get flat lesions called plain warts. You can get more tree-like or elongated warts called filiform warts. Then you can get plantar warts and periangal warts. Now, plantar warts sometimes are mistaken for corns or callosities. But how you distinguish is you get, if you especially scrape it with a surgical blade, you will see pinpoint areas of bleeding or pinpoint thrombosed capillaries. You can see these black dots here. That will distinguish this from a corn. So these are viral induced plantar wart. So now what's the treatment? Now virtually all treatment modalities of viral warts is done by inducing a inflammatory state, because viral warts are in the most superficial part of the stratum corneum, and so we don't have a good immune response, right? Because we don't have blood supply there. So treatment of choice is cryotherapy with liquid nitrogen. Liquid nitrogen is atmospheric nitrogen cooled to minus 196 centigrade to make it a liquid and applied. Now, viruses are not destroyed by liquid nitrogen. In fact, in research labs, they are stored in liquid nitrogen. But basically, we are using the liquid nitrogen to damage the epidermis, damage the stratum corneum to augment the immune response. So that usually if the wart takes 2-3 years to clear up, here it will clear up in 3-4 months. So repeated application of liquid nitrogen damages the skin, leading to clearance of the wart. Same way salicylic acid, trichloroacetic acid, they damage the skin to bring this about. Same way imiquimod augments our immune response to cause the wart to be cleared earlier. So speaking of warts, this is a patient who turned up at my clinic. She came in a wheelchair, 9-year-old, and if you look at her posture, now she was referred for me for the treatment of recalcitrant warts. What do you mean by the term recalcitrant? Resistant, isn't it? Treatment resistance. If you look at her posture, what do you see? It's an odd posture. She's stooping forward, head is turned to a side, as if she's almost inattentive, and she's supporting her trunk with her upper lips. So this is a typical posture of what condition? Do you know? Anyone? I'll give a clue. If you look at her eyes, you can see.
Dermatomyositis.
Yes, dermatomyositis also can cause a proximal, muscle weakness. So they can have difficulty in raising their arms or getting up from a squatting position. But usually that's involving the limb girdle initially. So they don't support their trunk with the limbs because their limb muscles are even weaker. Right? They will commonly come with difficulty in combing their or getting up from squatting position. Here it's due to a truncal weakness when you can see them supporting with their limbs. So their limb girdles are relatively working well. If you look, you can see what you see, especially in the sclera on the equatorial plane, you can see telangiectatic blood vessels, isn't it? Don't worry about this arrow for the moment. So what do you think this condition is? So she's come for warts. Hmm? It's not a very common condition, but sorry, go on.
Ataxia
Right.
telangiectasia.
Exactly. This is typical posture of ataxia telangiectasia. So because of their weak muscle, the ataxia and their cerebral weakness, they look into a side, but their head is turned to a side, almost that they are not paying attention, and they are supporting their trunk like this. They stoop forward. So now ataxia telangiectasia, if you remember, is a cause of a primary immune deficiency. It's a common immune deficiency. If you remember our immunity, we have a innate immune response in the neutrophils, macrophages, and then we have adaptive immune response. which is again divided into humoral, which is done by the B cells and the antibodies, which is for exogenous pathogens, and the cell-mediated immune response, which is for intracellular pathogens mainly. So condition like ataxia, telangiectasia work. The effects are both. It's a combined immune deficiency, isn't it? So I remember it during my training as SID was ataxic. So severe combined immunodeficiency is Scott-Aldrich syndrome, and ataxia, telangiectasia are causes of primary combined immunodeficiency. Primary means since birth, unlike the acquired causes, right? So when you have immunodeficiency, you are more prone for viral infections. Same way, they are less likely to respond to treatment, isn't it? Because as I mentioned, all the treatment modalities are directed at clearance by our immune system. So it's autosomal recessive disorder. So I'm not going to talk much about this because I'm sure you all will teach me. You all probably know about it more than I do because of its pediatric component. So they can have other skin manifestations like seborrheic dermatitis, cafe au lait macules, which I wrote, keratosis pilaris, and as in this patient, viral warts and dilated conjunctival vessels. They can have elevated alpha-fetoprotein, carcinogenic antigen, and due to the immunodeficiency, they have a much higher risk of malignancy. Especially in younger children, they come with hematological malignancies, and older people, they come with solid organ tumors. Moving on, so this rash, it's annular rash. In a 6-year-old on the left inner thigh for 3 weeks duration. So what are the possibilities when you get a thing like this? Think of the common things first. What would you think of? An annular scaly itchy rash. Tinea, isn't it? You would think of a tinea, isn't it? Or ringworm, as you call it. What are the other possibilities where you get a scaly annular rash? You can get things like the herald patch of Pityriasis rosea, which Pityriasis rosea, right? It's often after viral infection or a drug, you get initially one patch, which has a colored scale, and then you can get so many tiny patches coming in a distribution. You remember? But this one, it's not a typical colorate, but we define irregular scaling. This is the tinea, right? So this is tinea corporis. Now in children, it's not very common to get tinea. Often if a child has a tinea, either a parent or a servant or a caregiver, someone has tinea. If a child comes with tinea on the cheek or perioral area, don't forget to, especially in a lactating child, don't forget to check the submammary area of the mother. Often it's from contact from those areas. So however much you treat the child, unless you treat the contact, the mother in this case, you won't cure it. And depending on the site of tinea involvement, we give it different names, right? So tinea can affect the skin, yeah, and the nails, right? So tinea often we see altered by steroid abuse, right? So people give combination creams with steroids, antifungals, antibiotics, so it becomes very complicated to diagnose. But typically, it presents with an annular edge, and it can involve the face and the earlobe. These are actually adult patients I have put, but usually it's asymmetrical. Now, in the face, tinea can be photosensitive. They might complain of burning sensation or redness when you go in the sun. So you can actually mistake it for a photodermatitis, but usually it's very asymmetrical because it's infection, it's either one cheek or one ear. So it is a clue that it could be a tinea. So the next patient has an ear lesion. So before we move to patient 13, do you all have any questions? Probably not. Hello? No questions?
No,
Sir, sir, there's a
Right. So
question
this is a
came on the
3-year-old boy. Sorry, I can't hear you. What did you say?
sir, there's a question in the chat box meant for
Okay.
atopic dermatitis and HFMD. It's from Dr. Amila Gunawardena.
Yeah.
Uh, meant for
Let me
atopic dermatitis and
have a look.
HFMD. So
What
There
I
is a question,
meant,
right? What I'll do is I don't want to go away from my presentation just now in case
uh,
you'll have the former problem before. At the end of my
Okay,
presentation,
sir.
I'll talk about
Okay, sir. Okay, sir. Okay,
right. So this is a 3-year-old boy from Kakirawa. So Kakirawa is a bit of a clue. So it's a painless, non-itchy lesion for 4 months duration. So what do you see? You can see involvement of the yellow, which is indurated. You can see some scaling. There's erosion, with a bit of oozing. But there is no lesion on the yellow, the tip of the yellow. So generally, if in conditions like leprosy, you will have prominently yellow involvement, the tip of the yellow, right? And you won't, it's not very common to see oozing. So child from Kakirawa, non-itchy lesion, you have to think of, especially when it's going on for several months, think of leishmaniasis, cutaneous leishmaniasis. Now, generally in skin, if a lesion is localized, if it's itchy, it's not very worrisome, right? Uh, Conditions like leprosy and leishmaniasis, malignancies, they are usually localized lesions are not, itchy, and they are more worrying. So when a lesion is itchy, we are less worried, really, right? I'm not talking about generalized pruritus, which can be associated with malignancy. I'm talking about a localized itchy skin lesion. So this is cutaneous leishmaniasis. Usually they last for months, sometimes even a year or two. And originally most of the patients were from areas like Valley or Hammantute, but now you can get it anywhere in the country really. So travel history is important. And usually it's in an exposed area of the body. And you can get erosions like this, or they can come with these dermal nodules, usually in the exposed area of the body. In Sri Lanka, it's caused by Leishmania donovani, Sirawa MON37. It's due to the bite of a infected flea bottomine sandfly. So usually these can be treated effectively with intralesional antibody compounds. In Sri Lanka, we use sodium stibogluconate, which is an antibody compound, or cryotherapy. Usually we treat it because it can lead to severe skin scarring. And although the organism in Sri Lanka is Leishmania donovani, which is a cause of visceral leishmaniasis, in Sri Lanka, visceral leishmaniasis is extremely rare. There have only been a few reported cases. So this is again a fairly common presentation we see in our skin clinics. Also fairly straightforward. So this is a pruritic rash on dorsum of the foot for 2 weeks duration. Anyone? What do you think this is?
Hookworm investigations.
Sorry, can you speak a little louder? I can't hear.
Visceral lava
Hello?
migrant.
This is cutaneous lava
Cutaneous.
migrans. Cutaneous lava
Yes, sir.
migrans. So basically, lava migrants is due to animal parasites, right? So hookworms, roundworms. So the hookworm of the dog or cat causes cutaneous lava migrants, whereas the roundworms of the dogs or cat can cause visceral lava migrants. Again, it's not common in our country. Cutaneous lava migrants is commonly seen in children or adults who come into contact with soil or grass which has been contaminated with animal feces. And these larvae, although they need actually the dog or the cat to complete their life cycle, and we are just the accidental host. They can't complete their life cycle. The larva burrow through the skin, travel about until they die. But this causes a intensely itchy rash reaction in our skin, and it is a progressive. It migrates from day to day. It moves forwards. So the older part heals while the advancing part shows inflammation. So so these are also similar presentations. So treatment, we can either give cryotherapy to the advancing edge to kill or freeze the lava. Oral albendazole can be used. More severe patients and non-responding patients, we give ivermectin. It's important to treat the itch as well as sometimes they are secondarily infected, and also important to prevent a recurrence by avoiding soil contamination and deworming the pits. So this is a patient, the rash on the sole, a 13-year-old, bilateral soles are involved, asymptomatic rash. So what do you see? You can see the normal dermatoglyphics or the fingerprint or toe print marks are destroyed. It's lysed. You can see the skin has kind of thinned out. So what is this? This is called pitted keratolysis. So this is very common, especially in older children, who are going for tuition classes from morning till night wearing socks and shoes. So it's a very moist, humid environment inside the shoe. And in adolescents, they sweat more. So it's an extremely good environment for bacteria to proliferate, especially corynebacteria, phytococcus, which can lead to this condition called pitted keratolysis. They produce certain enzymes which lyse the keratin, right, leading to this condition. So treatment is with topical antibiotics, but in more resistant cases, we give oral erythromycin or clindamycin and advise about footwear as well. So this patient has presented, I don't know if it's clear to you, multiple hypopigmented patches which have been there for 6 months with a sensory loss to temperature. Can you make a guess? What is this? When you have a
Leprosy.
sensory loss, yes, you have to think of leprosy, right? Now, bear in mind, if you remember basic physiology, touch and pressure are carried by different fibers from pain and temperature. So sometimes, or often rather, the earliest damaged fibers are the ones carrying sensations for pain and temperature. So especially in areas like the face where there's a very good innervation, there may not be a sensory loss to touch. But if you check for temperature, invariably temperature loss will be there. So it's very important if you are suspecting a patient is having leprosy to check for temperature if there is no sensory loss to touch. So this is actually borderline leprosy. Now, leprosy is a very confusing topic to a lot of trainees, but actually, if you know the basics, you can easily work out the rest. So, what you need to know is a chronic infection or a mycobacterium. So, classically, we talk about Mycobacterium leprae, but over the last couple of years, another organism has been discovered, Mycobacterium lepromatosis, which is contributory to most of the leprosy patients, especially in America, where it leads to more diffuse cutaneous leprosy. But it has also been reported in India. So mycobacteria obligate intercellular parasites. So obviously our humoral immunity with antibodies don't have much effect. So we have a cell-mediated immunity which gives a good fight against the organism. So usually the bacteria grow in Schwann cells and skin adnexal structures. What are the adnexal structures of the skin? The hair follicles, sweat glands, the nerve endings, the sebaceous glands, etc. So these are where you find the bacteria. And usually it prefers a cooler temperature, not 37 centigrade. So that's why you won't find leprosy patches in the armpit, groin, or the scalp, which are warmer and have a good blood supply. So if you find a hypopigmented patch in the groin or the scalp, it's not leprosy. And it's a very slowly dividing bacillus. So for one bacillus to become two, it takes 12 to 14 days, unlike E. coli, which they divide in 20 to 30 minutes. As a result, it has a very long incubation period. So once the organism enters your skin, I mean, enters your body to get skin lesions, it might take 9 months to 20 years. And it has a low infectivity. Majority of people who get the bacillus don't get it. Right? Now, if you know this, you can actually work out the condition. So this is like a war, right? So our army is our cell-mediated immunity. So if you have a healthy cell-mediated immune response against Mycobacterium leprae, it's more like a localized skin disease. You'll come with one or two patches which are well demarcated because our immune system is localizing it. There'll be very few bacilli inside, but due to the immune response, when there's a war, there's damage to the surrounding structures. No, innocent bystanders also can get killed. So as a result, this grows around our skin adnexae. Those are damaged. So nerve endings will be damaged. So you get sensory loss. Damage to the sweat glands will reduce to anhydrosis. You won't get sweating. Damage to the sebaceous glands lead to dryness and scaling. Damage to the hair will lead to loss of hairs. So it's a hypopigmentation, and damage to the melanocytes will lead to hypopigmentation. So that's why you get a hypopigmented anesthetic patch. Whereas if our cell-mediated immune response is poor, it's more like a systemic disease. You'll have very ill-defined, very vague patches all over the body. Nerve thickening won't be as common. Nerve damage won't be as common. But if you do a smear or a biopsy, it will be teeming with bacilli. And they will have other systemic features just like a systemic disease. Glomerulonephritis, peripheral neuropathy, testicular atrophy, gynecomastia, so many other problems. Because leprosy can affect any organ in the body except the central nervous system, that is the brain and the spinal cord, and the ovaries and the lung. Right? Now, in children, we are, especially as dermatologists and even epidemiologists, are very, very concerned about leprosy in children. Why is that? Not necessarily because of the damage to their quality of life and they are the future of the country, but for another reason. Now, as I mentioned, it takes up to 20 years for the disease to manifest. So even if we eradicate leprosy transmission in Sri Lanka today, new patients will turn up to 20 years from today. So we have no idea how well we have controlled the disease. But we know if a child comes with leprosy, a 2-year-old child comes with leprosy, we know he acquired the infection within the last 2 years. So that's why we are very concerned about childhood leprosy cases, because that gives us an idea about the incidence of leprosy in the country. So you can have a solitary patch like this girl with sparing of the axilla, or you can have multiple patches, or like a systemic disease, ill-defined patches all over the body. Or sometimes they can come with pure neural leprosy without skin lesions, but with nerve damage coming with this claw hand like this child. Which can be, so leprosy can cause a lot of deformities and disabilities. So it's very important to detect it early. So you can have annular lesions like this, or even hyperpigmented patches like this as well. So it's important to keep a high index of suspicion. I'm not going to treatment now because we're short of time. Right? So we give a drug treatment. We give a combination of drugs to prevent resistance, just like in Mycobacterium tuberculosis, and to break the chain of transmission and to shorten the duration of treatment. Usually we treat anywhere between 6 months to 1 year, rarely up to 2 years. So moving on, this patient, this is a 12-year-old boy who came with focal seizures, developmental delay, and he was referred to us with this papular eruption of the face. So focal seizures, developmental delay, bit of mental retardation. What runs in your mind when you see this?
Tuberous sclerosis.
Very good. Yeah, you have to have a high index of suspicion for that. So this is tuberous sclerosis, and these little bumps are called adenoma sebaceous. These are all hematomas. What is a hematoma? When you get an abnormal proliferation of tissue, non-neoplastic, because it's found in the tissue of the surrounding area. For example, now you know the heart has cardiac muscle, but if you get an abnormal proliferation of cardiac muscle in the heart, like cardiac rhabdomyomas, that's a hematoma. So it's the same tissue you found in the surrounding area, but it's an abnormal proliferation. So it's not a neoplasm. So this is tuberous sclerosis. Now, generally bear in mind, most structural abnormalities like getting bumps like this or like neurofibroma, those are often structural abnormalities are caused by autosomal dominant issues. There are rare exceptions. Metabolic problems like enzyme abnormalities are caused by autosomal recessive disease. There are exceptions though, but in most cases that's the case. So you can get non-cancerous hematomas growths in the brain, skin, heart, kidney, liver, eye, virtually anywhere. So depending on where the sites are involved, you get these symptoms. You can get lung, cysts, pneumatoceles, skin involved with so many manifestations. In the you get angiofibromas of the nails, isn't it? So sorry, subungual fibromas of the nail folds of the skin. Then you can get these adenoma sebaceum. Then you can get collagen tissue hematomas, which are called Sjogren's patches in the lower trunk. This patient didn't have much. Usually it's a skin colored large plaque. She had two tiny ones here and one here. You get ash leaf macules, which are elongated macules, hypopigmented macules, or confetti-like very tiny white dot-like lesions, which are called confetti-like macules on their skin. Now, in their these tubers, cortical tubers, subependymal tubers, astrocytomas, and even brain tumors, they can develop in life. So also generally bear in mind there is a temporal sequence. So earliest to come actually the cardiac rhabdomyomas. They are seen in 50 to 60% of patients. Usually it's in the antenatal period or in the neonatal period they develop this. So we have to have a high index of suspicion to detect this. Most of the skin lesions come on later, especially adenoma suspicion come in the older child. So you might miss it in a younger child. Just because you don't see it, don't think that it's not tuberous sclerosis. Seizures, developmental delay will come again in the infancy to the older child. So this patient came with this lesion. He was admitted with high fever for 5 days. He was from Kakira. He had come visiting his grandmother when he came with this rash. He had a high CRP. What do you think? What do you see here, first of all?
Ishka.
Yes, there is like almost like a cigarette burn, isn't it? But not only that, if you look carefully, you can see a small, yes, there are submandibular lymph nodes. So this is basically typhus. So basically, don't forget, especially if a patient comes with high fever, don't forget to examine especially the seams where the underclothes fit, the groin, the banion in the armpit. You can easily miss an SK. So typhus, the clinical features may differ depending on the organism and the area you find the organism. For example, you can get the spotted fever type typhus, which presents with a rash, which is seen in like Navalapiti and the mountainous areas, and the scrub typhus, which is seen in Anuradhapura, the scrub bushes areas. So that comes. This is a scrub typhus. Spotted fever can come with a this kind of more diffuse type of rash. Now you can have this kind of like fern leaf skin necrosis also, like in the picture on the right. This is also quite typical of typhus. Actually, this was first described by a Sri Lankan. So fern leaf type skin necrosis is also a feature. And generally in typhus, the rash is papulomacular. That is more palpable than the normal typical maculopapular rash. And it can involve the palms and soles. So we don't need to go into a lot of detail because we are running on time. And the last patient has this rash, which is also fairly straightforward. A 5-month-old preterm baby coming with exclusively breastfed, non-consanguineous, coming with diarrhea and fever. What do you think about this?
Ectoderma enteropathica.
Yeah, so by looking at this, what I can say, this patient is having a subacute zinc deficiency.
Yeah.
Now, zinc deficiency can be inherited or acquired. Now, if this patient had a history of consanguinity, I would think of ectodermatitis enteropathica. Even this child, it might be there, or it might be even acquired, because breast milk, although has a higher bioavailability, total zinc component is low, and especially when the child is born premature, their zinc stores are less because zinc is deposited in the last trimester. So they come with diarrhea, irritability, periorificial rash, and especially if it's consanguineous, it's autosomal recessive disease, then you have to think of ectodermatitis enteropathica. So it's very important to detect this because it's fatally untreated. So zinc is a cofactor in the synthesis of alkaline phosphatase, the coenzyme. Low serum zinc will result in low alkaline phosphatase levels. Since checking for serum zinc levels is very expensive and difficult, not found everywhere, alkaline phosphatase may give a clue, but usually it's a clinical diagnosis. So we have to replenish the zinc. So I think now we can move away from the presentation to the questions. I think there were some questions. Yeah, so let's go to the questions. Oh, sorry, briefly give the treatment. Okay, I'll talk about that roughly. So treatment for atopic dermatitis and hand, foot and mouth disease. Am I right? Amila, is that what you wanted?
Yeah.
Treatment for those conditions,
Yes.
no? And also, would you please show us the first dermatological condition discussed here? Okay, sure. Yeah, let's go back to that. I hope you all will see this time. So let's go first of all what I showed in the first slide. So this is what I showed, right? So a boy coming with this sort of rash, 3-year-old male with low-grade fever for 2 days, reduced oral intake, irritability, might have cervical lymphadenopathy also. So in addition to these sites, you can have involvement of the oral cavity, then knees, elbows, buttocks, right? So this is hand, foot, and mouth disease, right? So sometimes it can almost look like vasculitic. You can get like red patches all over and can be very tender. So you might even mistake it for vasculitis. So you can get a knee, elbow, buttock variant without any hand or foot involvement also. And especially in obese children, and perhaps in children with reduced immunity, children who have not been breastfed, it's common to have a more severe disease. And you can have sometimes in obese people, we even see like chicken pox, like widespread skin blisters. So you sometimes get confused whether it's chicken pox. So this is hand, foot, and mouth disease. So these are the oral lesions. So sometimes Coxsackie virus can, as I mentioned, this is caused by Coxsackie virus A16, A6, and enterovirus 71. Coxsackie virus can cause a condition called herpangina. Have you heard of herpangina? That is, you get oral lesions without any skin lesions. So they can have only oral involvement. Then we call it herpangina, and that's usually caused by Coxsackie virus. So they come with after like erosions, cervical lymphadenopathy, fever, macules which evolve into vesicles with erythematous halo, and Bose lines can be seen. So generally treatment is supportive. So you have to treat the fever, and they often can get dehydrated because of the oral erosion. So you are giving very soft food, not wet, some not anything very hard, and see that they are not dehydrated. And sometimes you might have to use antiseptic mouthwashes. So basically treatment is mainly supportive really. We don't have any specific treatment for this. uh, and enterovirus 71 is more severe and more likely to cause neurological complications. We spoke about it can cause acute flaccid paralysis, then encephalitis, meningitis, and rarely cardiorespiratory failure and death, which is very, very, very rare. So don't scare your patients by telling that. And it can be complicated with Bose lines, right? As in this patient who had hand, foot, and mouth disease 5 weeks ago. She actually came to me yesterday. So if you see the nails, you can often retrospectively diagnose hand, foot, and mouth disease also sometimes. So regarding atopic dermatitis management, I'll go back to that slide. Atopic can be polymorphic. They can present in so many ways. They often have dry skin. So management is actually stepwise management depending on the severity. So all patients need moisturization and proper bathing habits. So generally in Sri Lanka, we advise them to have a bath for 20 minutes, ideally immersed in water, not just in a shower, but immersed in water, not hot water, but normal temperature water, tap water. And you shouldn't use strong soaps, ideally a pH balanced soap or a medicated soap, or at least aqueous cream you can use as a soap. So you apply it on the whole body and wash it off. For the scalp, we often use something like 1 or 2% cetrimide shampoo because it helps with the scaling. Scalp scaling can be there due to scalp dryness. It helps with that. And also it reduces the risk of infection because atopics are more prone for infections. So ideally after bathing, immediately after wiping, it's the best time to apply moisturizers because then the water is retained as much as possible in the skin. So after bathing, we advise to apply a moisturizer, and the rest depends on the severity really. So we often, our patients, they need a topical steroid. So we use something mild like hydrocortisone. If it's more severe, there are other, treatment regimes we give as well. Also, sometimes we have to add treatments like tacrolimus or pimecrolimus, which are steroid sparing creams. They are topical calcineurin inhibitors, which are very safe. Initially, they were used in children over 2 years, but now there's increasing evidence that it's safer even in younger children. And they don't have the harmful effects of steroids like thinning of the skin, and development of the skin doesn't get addicted to it. You don't get rosacea, and so it's really beneficial. But they are much more expensive. Then using an antihistamine is important to break the itch scratch cycle. I spoke about how The sensation of itch leads to stretching, leads to epidermal barrier dysfunction due to the injury, physical injury due to stretching. So to break that, we often add antihistamine. And it's very important, especially in young children, their nails grow so fast, unlike adults. We advise the patient to keep the nails short, at least cut the nails maybe once a week or once in 2 weeks to cut their nails short. Also, other triggers like insect bites, mosquito bites, those have to be avoided. So use a mosquito net and or insect repellent or vaporize or something to prevent insect bites. And synthetic fibers like nylon can worsen eczema, nylon and wool. So we advise preferably cotton or rarely silk, but cotton is better. Now overseas they have special garments, impregnated with impregnated with silver, or you get this Aegis underwear, which again has been impregnated with an antiseptic compound, which is non-allergenic, so which help in preventing allergy or irritation with clothes. And sometimes, especially if there's a lot of oozing, we use wet wraps where we apply a steroid or a moisturizer and wrap up with soaked gauze and keep it overnight. And in the more severe patients, we might consider other alternatives like phototherapy or light treatment, but only some people respond to that. Or oral drugs like cyclosporin, methotrexate, azathioprine, but preferably in older children. But sometimes if we have no option, even in younger children, it's very important to check for compliance, because it's very common that these children are not bathed properly, especially the grandmothers don't like to bathe these children because they are very prone. Atopics are more prone for respiratory tract infections, coughs, colds, and especially when they go to school, they catch all these things. So grandparents don't bathe them, think una hembirisawa. So then their skin flares up. It's very common to get secondary infections because their skin anyway has a higher rate of colonization with staph MRSA. So, and skin infections can be more severe in them. So that's very important to treat secondary infections also aggressively. So in a nutshell, that's what I can tell about eczema treatment, but it's a topic by itself. So I can't talk a lot about it, but basics, it's summary that's what I would suggest. Right? Any other questions? Okay, so there has been yeah, anyway, this presentation, someone has asked whether I will share this presentation. Yeah, this has been recorded. So I think Mr. Sudarshan will give you all the link to that so that you all have a link to that. Right? So you all can access that. So how there's been another question. How do you differentiate vasculitis from hand, foot, and mouth disease? Well, first of all, vasculitis, the the presentation is slightly different. Now, vasculitis typically comes in dependent areas, right? You will have, especially around the ankles and the feet. It's very unlikely you will have it on the face, elbows, knees, things like that. So it will be more on the dependent areas. And usually we do something called diascopy. That is, now what happens in vasculitis, you get leakage of blood outside of the damaged blood vessel. So diascopy simply means you press a skin lesion with a glass slide or a spectacle. When you press on it, if it's due to vasodilatation, when you press on the blood vessel, it empties. So the redness goes away. But if it's vasculitis and the skin blood vessels are damaged and there's leakage of blood outside the blood vessel, if you press with a glass slide, it won't empty. It will still remain red. So vasculitis, redness will be there. So hand, foot, and mouth disease, it can rarely cause vasculitis by itself, but usually these lesions won't be exactly only restricted to dependent areas. We'll have it knee, elbow, buttock, or hand, foot, and mouth distribution. There'll be preceding history of fever, and there might be a contact history, right? So it's not difficult. And also the individual morphology of the lesion, this vesicles, blisters, whereas in vasculitis, it's more likely purpuric lesions, so it will help. But sometimes it can be tricky, as I mentioned before. ESR levels certainly will be high with vasculitis, especially if it's a systemic vasculitis. But even otherwise, it will be often elevated. Hand, foot, and mouth disease without any complications, I don't expect it to be very high. but it certainly can go up, especially with more diffuse and more severe disease. So I think that's all, isn't it? Any questions I missed? Is that clear? Any further questions? Okay, right. Glad to hear that. Okay, then good luck with your exams and studies.